Okay. Thank you for the opportunity. Good morning, the facilitators, senior colleagues and colleagues. In the next few minutes, I'll attempt the practice question for E. It says a 37-year-old IT professional has complained of 2 days history of headache and fever with temperature measured at home at 39.2 degrees centigrade. He has been seeing the ENT surgeon for recurrent ear infection. He drinks alcohol up to 40 units per minute per week. He lives with his wife and 2 children who are currently okay. The headache is worsened by noise and light. On presentation, he has a fever of 38.8 degrees centigrade and neck stiffness. However, he is conscious and can obey commands. He is being nursed in a quiet and dark room. The fundoscopy was normal. He had a normal lumbar puncture. And CSF results were as follows. CSF glucose is 1.2 millimoles per liter. CSF WBC count marked elevation with predominant neutropenia. His random blood sugar was 5.8 millimoles per liter at the time of sample collection. What's the diagnosis? Which 2 clinical signs will be useful to elicit in this patient? What is the most likely causative organism? Which investigation or procedure will you do in his management? How will you manage this patient up to discharge? The likely diagnosis is sporadic bacterial meningitis. Looking at the parameters, the hypoglycemia, the predisposing factors, alcoholism, ear infection, and having phonophobia and photophobia, and with the biochemical findings in the CSF. And because he's alone that's having the illness, it's likely to be sporadic bacterial meningitis. If there are many people around him with a similar illness, probably it could have been epidemic meningitis. Which 2 clinical signs will be useful to elicit in this patient? The clinical signs going to be Carnick and Brzezinski signs. So what's the most likely causative organism? Looking at the age of the patient and the predisposing recurrent ear infection and also the alcoholism in the patient, the commonest organism in this age group and people that consume alcohol and people that have otitis media, as mentioned in the history, is likely to be Streptococcus pneumonia and is one of the commonest cause of sporadic bacterial meningitis. Which investigations or procedure will you do in his management? Other investigation that we'll do is to do CSF microscopy, culture, and sensitivity to enable us culture the particular organism and also to be able to have a sensitivity pattern of the bacteria. Also, it's important to do a blood culture in these people. Probably he has a bacteremia, although from the history and recurrent air infection is likely to be local contagious dissemination to the brain. But as well, we can do blood culture. Also, we need to do air swab. If still he's having discharge, we could do air swab microscopic culture sensitivity so that to be sure, is it the same organism or is having different organism and the sensitivity pattern as well. Full blood count is important and differential. May see white cell count also may be elevated with predominant neutropenia as in the CSF full blood count. Electrolyte urea and creatinine is important. Also, some of them may have hyponatremia And then liver function test is important. We remember this person consumes alcohol, so it's important to know the liver status of this patient. And for the electrolyte urea and creatinine, some of the medication that we want to commence him on may have a nephrotoxic effect, so it's important to have electrolyte urea and creatinine. Since he's consumed alcohol, it's a possibility that he might consume other things. So urine toxicology is not out of place. Question 5, how will you manage this patient after discharge? It's actually going to be a multidisciplinary approach involving infectious disease or neurologist, then the ENT surgeon, gastroenterologist, psychiatrist, or psychologist might be involved in the management of this patient. At the acute phase, the most important, we need the neurologist and all infectious disease specialists. We commence the person and the meningitic dose of ceftriaxone plus IV vancomycin, because it's the commonest, the organism is sensitive to it. While adding vancomycin, some of the commonest organisms like the Streptococcus pneumonia, they tend to have resistance to the commonest beta lactams around. So we are adding vancomycin to suppress that. Then the dexamethasone is significant in the management of this patient. Is aimed to start the dexamethasone few minutes before, about 1 hour to 30 minutes before a commencement of antibiotics. This is in order to limit the extensive inflammatory changes around the brain. The studies have shown that with dexamethasone or with steroid, there is a better prognosis in terms of neurological sequelae that could happen, especially in patients that are having sporadic streptococcal meningitis or sporadic Haemophilus influenza type 2, type B meningitis. Then supportive IV therapy is important, and also the duration of antibiotics should be up to 14 days. The role of ENT surgeons, the treatment of otitis media using likely above antibiotics, and also he may require surgical intervention and or daily dressing. The gastroenterologist, after stabilizing the patient, they may need to come in place in order to screen or treat the alcohol-related chronic liver disease if as appropriate. And also the psychiatrist or the psychologist, they may need to come in place after stabilizing this patient before discharge, and then also to treat and manage the alcohol dependence. Then the follow-up has to be recommended for the patient, and patient will be followed up. If there's no problem, will be discharged from the clinic completely and hand over to the psychiatrist and or ENT surgeon. So just brief about the overview of bacterial meningitis. Sorry, I couldn't have enough time to write much. Bacterial meningitis is a medical emergency. You need prompt administration of parenteral antibiotics to save life. An inflammatory process usually involves the meninges, cerebrospinal fluid without involvement of the brain tissue due to the presence of bacterial or viral pathogens. The brain is protected by the skull, pia, arachnoid, and dural meninges, as well as blood-brain barrier. When these defenses are breached by a microbial pathogen, an inflammatory response occurs within the cerebrospinal fluid. Bacterial meningitis may be caused by hematogenous spread or spread from contagious sites like otitis media, as we mentioned in the index patient. Higher income countries, they have it's prevalent, but it's about up to 10-fold higher in the developing countries. Mortality is very high, especially among the children. Usually they present as emergency. Neisseria meningitis associated meningitis occurs usually as outbreak, but the other ones usually present with a sporadic case. Pneumococcal meningitis outbreak has also been reported in some places in Africa. The classification has various classification, could be community acquired or nosocomial acquired. That's based on the location where an individual acquired the disease. Even at the level of the community, we could have sporadic or epidemic cases, and they could also be classified based on the pathogen, whether it is viral or bacterial or fungal in origin. And also based on time duration could be classified either acute, subacute, or chronic meningitis. The causative organisms, some of them are outlined here: Streptococcus, Haemophilus influenza type 2, Neisseria meningitis, Listeria monocytogenes, especially among pregnant women and individuals with diabetes mellitus. Streptococcus agalacea is common among neonatal age group. Clinical presentation: the triad of acute onset of fever, neck stiffness, and octundation, and photophobia, nausea, and vomiting, physical examination, Carnick-Brzezinski signs, and also they may have petechial or hemorrhagic bullae is a case of Neisseria meningitis. Papillary edema may be there, and focal neurological deficit may be there due to vasculitis and vasculitic stroke-like state. Laboratory studies: lumbar puncture and CSF analysis, cell count, differential glucose, and protein. Usually they tend to have, in bacterial meningitis, they tend to have hypoglycemia. Can do polymerase chain reaction and other serologies, especially for other patients. The drawback of this, we may not have the ability to have the sensitivity profile of the organism. Gram stain and culture will give us the sensitivity profile. Then for the viruses, these are the viruses that we could identify in the course of PCR. Additional tests include serum glucose level in order to compare the serum glucose and the CSF glucose. The serum glucose is usually taken prior to lumbar puncture. LFT, complete blood count, blood thrombin time, and other clotting profile are important. Brain imaging is important in management of this category of patient, especially a patient having to rule out the contraindication for lumbar puncture. The management, the table below depicts the commonest organism based on the age and the commonest empirical antibiotics. Like in the patient that presented earlier, the age group of 2 to 5 years, the commonest organisms, Streptococcus pneumonius, vancomycin plus third generation cephalosporins are common organisms used in those age group. Above 50, we tend to add ampicillin because of Listeria monocytogenes. Dexamethasone use in meningitic patients has been linked to decreased hearing loss, neurological sequelae, and mortality. And this is because with the administration of antibiotic, there is a rapid killing of the organism. All the endotoxins that are generated will elicit inflammatory process by elaborating or stimulating the release of interleukin-1, interleukin-6, and tumor necrosis factor alpha. So by administering steroids, it dampens these inflammatory changes. Routine pruning restriction is not recommended and could be detrimental. Treatment of complication, if present, is important. Conjugate vaccine has been found to reduce the prevalence of Haemophilus influenza type B, pneumococcus, and also meningococcus vaccine incidence in high-income countries and even in Africa. Thank you.
Thank you, Dr. Dalhat, for this lucid presentation. It's actually a very good one. Thank you, thank you. We entertain contributions from our colleagues and from our latest fellows. If there is one or two things to add based on the experience you noticed during the exams, or some of our colleagues that have one or two things to add. Thank you. But okay, Dr. Tanimu want to say something. Go ahead, sir.
Thank you very much, Dr. Alhati, for this very good presentation. It's a nice one. When they say what is the diagnosis, I think it's better you said just bacterial meningitis. As they give you the CSF finding more in support, low CSF glucose in relation to serum glucose and other parameters in the CSF analysis. So it's better you go for bacterial meningitis, not sporadic, because there is focus of infection. In sporadic meningitis, there is usually no focus of infection. But here there is a catch where they said he has air discharge. So, so it's better you say bacterial meningitis, and so most of us said that bacterial meningitis without saying sporadic because there is focus. So that is it, and I think they have given us our marks by God's grace. Thank you very much, but it's a nice one. Keep it up. Thank you.
Thank you very much, sir. Dr. Allison or Imola, they want to say something. Go ahead.
Yes, thank you. Thank you so much. Just from experience, thank you to the presenter. Very lucid presentation. For question 3. Okay, question 4. Which investigations or procedures will you do? You know, you've been given lumbar puncture and the likes, so they needed a focused investigation per se. All the ones, please let me go to your slide where you answer the questions, please. So all these would have been mentioned in your management. That was where it was expected to be mentioned. So the procedures that were needed here needed a brain neuroimaging. You know, this patient has otitis media or discharge. You have to be sure there is no abscess collection. So they needed a CT scan, a brain CT scan in this patient. We've been given LP and the likes. So it's a CT scan. And the second thing should have been like an otoscopy. You have to examine the hair where the discharge is coming from. So those are the 2 investigations that I feel are appropriate here. Those were the ones. So all these other ones, we go to the management of your patients. So other things you would like to do in the patient and all these to look for other things, we go to management. So that's my take on that. Then, you know, this patient uses alcohol, and alcoholism is also a form of immunosuppression. It suppresses the immune system. So we would also be thinking of adding amoxicillin or ampicillin for these patients due to the fact that it is at risk of immunosuppression. So I think that should be part of your antibiotics. And another thing is, even on to discharge, you have this patient has relatives, they even mentioned in the history, and people that stay around with him. So you must also give them prophylaxis if they are not immunized. That's the relatives now that stay with him or those that are exposed. And you give rifampicin or ketrazone, single dose IM, or fluoroquinolones, all out 500 milligrams, single dose. So those are the 3 drugs that I feel should also be part of your treatment onto discharge. And for these patients too, after managing, you also have to be certain if patients has been immunized or not. If he has been immunized, there is room for booster doses, especially knowing that it has risk of recurrent infection. So I think that's part of what they want to hear until discharge. Yes, you mentioned alcohol and the likes. We will also require psychiatry and the likes. So those are my comments. Well, thanks so much for the presentation.
Thank you, Ma, for this addition. Thank you. But I just want to ask Ma, related to the question you Is it a recommendation that alcoholics are given prophylaxis for listeria? I used to know pregnancy, severe immunosuppressions, elderly and children less than some years. I don't know. Oh, it's something
Yes, I
that
understand what you're saying. Well, I felt there was a catch with the alcoholism. I mentioned it and I was scored. So that's why I'm saying that. Yes,
okay,
thank
you,
you.
ma. Yeah. Chief Success want to say something again to the group. Go ahead, ma.
Okay, good morning, my teachers, new colleagues and colleagues. Thank you so much, Dr. Dahalto, for this lucid presentation. I want to say that please, Dahalto, after our comments, there are some slides you might need to correct. Please effect it before you send to the group. I also want to thank Dr. Remigos. I know he predicted this question and it came to pass. Okay, so Dahalto, before I make my comments, please, I want to ask you a question. You said in your slide that the commonest cause is strep pneumonia. Why is it not necessarily meningitis?
Okay, thank you very much for the comments and the question. For why is it strep pneumonia? Because of the focus of infection. The commonest cause of otitis media is strep pneumonia, and in this patient, he has recurrent otitis media, and it's likely to be contiguous spread. And also, Neisseria meningitis usually is epidemic. It comes in epidemic meningitis. From the question, they clearly stated that he's the only person with the similar symptom. So I felt it's likely to be streptococcus pneumonia. Thank you, ma.
Okay, thank you so much. Because I know that in this question, some persons are also marked for Neisseria meningitis. Okay, so I want to add one or two comments concerning the treatment. Okay, I think treatment, I should say that last. Okay, let me just say, concerning the treatment, okay, so we can do supportive care, okay, which I was thinking that you add things like, giving antipyretics and so on, which was not in your slide. So supportive care is important for this patient, raising the head of the bed to 30 degrees and so on. Okay, then you want to give broad spectrum antibiotics. Now, it is important to say that after the result of the CSF is out, you now want to convert to specific antibiotics. Okay, so according to the microorganism that is cultured, please, that should be reflected. Okay, so we do broad spectrum because of course, epidemiologic studies. But then when the results, okay, of the CSF are out, we might need to now convert to specific antibiotics, okay, that's specific to the microorganisms. Then, of course, we want to go to our ENT. Please, important for us to say rehabilitation. Orimolade, thank you so much. They actually scored up to prophylaxis, yes. When I said prophylaxis, I will give you that rifampicin or ciproflox. I saw them scoring me. So please, it should also be part of your management strategy. So of course, you want to rehabilitate this patient. So it should be seen, yeah. So part of rehabilitation may be psychological counseling, of course. And of course, you want to use these 5 A's, okay, in alcohol cessation. Another thing I want to say is somebody put in the chat that the procedure of fundoscopy is actually not fundoscopy. In the result, in the stem, in the question, okay, they said that fundoscopy is normal. Okay, so they're asking for another procedure you want to do for this patient. Okay, so which I think is the otoscope. Please let me see the investigations. I wonder why you put in anesthetics in the ear swab MCS. That's one of the very important investigations you also want to do for this patient. Okay, so it shouldn't actually be stereo. So you add the CT scan that Orimolade talked about. Thank you so much. Then I want to say that next time when you are telling us about the etiology, please put it under groups, okay? So which microorganism do we see in patients that are in the neonates? Which do we see in patients 1 year, okay, to 5 years, or in the adults, okay, early or young adults, elderly. Okay, so I think it should be in that manner so that so that we treat. Yes, I didn't see it in the other slide. Thank you so much. Then finally, I want to say that if you in your management or in your diagnosis of meningitis, you said fever, altered mental status, and neck stiffness, but you didn't call headache. Okay, so usually there are 4 symptoms: fever, headache, neck stiffness, and and altered sensorium. Now, 2 out of this, we can actually make a diagnosis of meningitis. Okay, so when you have 2 out of these 4, you can actually make a diagnosis. However, we know that, so I didn't see headache in those, so please, it's important for us to, yes, you can, of course. So the classic triad, you say it's fever, neck stiffness, and altered sensorium. You didn't put headache. Okay, so it's actually 2 out of these 3. You can actually make a diagnosis. Some persons make the triad to be fever, headache, and even neck stiffness. Thank you so much. These are my small.
Thank you, Dr. Success, for this great addition. Thank you very much. We appreciate. I think before we proceed, I just want to have one comment. I must acknowledge Dr. Alhatu for this very good presentation. And I just want to emphasize on use of dexamethasone. It has both additional and it has both advantage and disadvantage. As we mentioned, one of the advantages is that, most of these antibacterials, they are bactericidal. They cause killing of this organism. And in such doing, there is the release of these mediators, inflammatory cytokines, interleukin-1, thermonecrosis factor. And when they are there, they disrupt blood-brain barrier and they cause increased flammability in the brain. So, and if you give antibiotic, if you give steroid after these bacteria have started their effects, it has shown not to work, not to suppress those inflammation to some extent. So that's why it's advisable to give, there has to be dexamethasone there waiting for the antibiotic to start the cascade. So the dexamethasone it's present in the blood will not allow those to happen. And patient will have easy recovery. The antibiotic will get to work. And sometimes you can give it at the same, if you could not give it 30 minutes, as we mentioned before the time, you can give it together. It has also as well shown to have a beneficial effect, but it never the reverse, meaning if you not give antibiotic, then you give dexa. The efficacy is not more because once the cascade is stimulated, it may not avert that. Then, but again, as we highlighted again, studies have shown that it's associated with some hearing abnormalities because it causes hippocampal sclerosis. We all know the functions of hippocampus in memory. So it causes some hearing abnormalities, memory and hearing. However, again, for this index patient that we think of giving vancomycin, it also has shown that it reduces the penetration of vancomycin into the CSF. And some guidelines advocated increased normal dose of vancomycin in a certain way you have already started the steroid. Though it's just a recommendation just for us to have an idea. Thank you very much, by the way. It's a very good one. I think, let me read out from the chat. Okay, I think somebody mentioned, okay, Dr. Rukaya said, meningitis triad is fever, headache, and neck stiffness. Meningitis alone doesn't exactly cause altered mental status. This usually results when there are complications. So most commonly when there are complications is when especially the viral, they don't usually come with some altered, they present more with this fever, headache, and neck stiffness. And I think those are the things from the, some other chat has been mentioned again. And Dr. Rukaya again said, well done, Dr. Dalhat. Nutrition is, you want to emphasize on the effect of nutrition in this kind of patient is very important in the management. So management, make sure they are getting their, if they are NG2 or whatever form of feeding, they are well nourished. It's very important. And Dr. Ade also asks, what is the relationship between serum glucose and CSF glucose? Thank you for this good presentation. So I think those so far from the box I can see. Then Dr. Afolabi also said, Dr. Afolabi, sorry, I'm coming. Dr. Afolabi said again, thank you for the presentation. Is this clinical scenario a case of sporadic meningitis or acute bacterial meningitis? What, is there any difference? And somebody also asked similar question, why do you choose sporadic bacterial meningitis as your diagnosis rather than just acute bacterial? I think Dr. Tanimu said something about that, but if you want to respond, you can do that. Thank you. Dr. Florence want to say something. Go ahead, ma'am.
Okay, good morning, senior colleagues and colleagues. I think for the causative organism, Listeria monocytogenes is not far-fetched, being that if you look at the history, the patient already takes 40 units of alcohol per week, of which is kind of massive. You know, I think right now they said 14 for both males and females. So here there's a form of alcoholic abuse. And we all know that in alcohol abuse, what happens is that there's impairment of absorption, there's also utilization problems, and then storage problems, and as well excretion problems of nutrition. So nutrition here is usually impaired, like in the aspect of absorption, utilization, storage, and excretion. So all of these will now cause for inadequate intake of nutrition, and then to bring about nutritional immunosuppression. And we know that Listeria monocytogenes is found in patients who are immunosuppressed, the diabetics, extremes of age, and all. So I think Listeria monocytogenes is not far-fetched in this patient. And then we know that when there's Listeria monocytogenes, we have to add ampicillin, you understand? So it's not far-fetched, even if there's a background history of an ear infection. So I think the unit of alcohol being put in here is for a purpose. So I think that is not far-fetched if one mentions Listeria monocytogenes, because chronic alcoholism or alcoholic abuse patients are usually immunosuppressed. So that's what I just want to add on to that. Then again, I think Dr. Tanimu already has answered the question why it's not sporadic. He said because in sporadic there's no focus. You understand? But here they said that there's an issue of an ear infection. So I think that's why he said it is bacterial and not sporadic. So that's just what I want to add to. That's my contribution. Thank you.
Thank you, ma. Thank you very much. I think, ma, why he considered strep pneumo better than Listeria is, yeah, even alcoholic, even is in non-abuse, even is not in abusive mode. Strep pneumo is implicated. Otitis media, strep pneumo, sporadic meningitis, strep pneumo. I think that's why he gave more weight to strep pneumo. However, as you said, one may, on the other hand, also think of Listeria monocytogenes. Thank you.
Hello, Dr. Yahaya.
Good morning, ma.
Okay,
Hello,
somebody wants to speak. I want to just make a comment quickly, so I will move to the next presentation.
Okay, ma.
I want to say that I must appreciate Dr. Dahatu. I think this is his second presentation, and he did well. He did wonderfully well. Please, in exam, keep things simple. You understand? Keep things simple. Common things occur commonly. You understand? I agree with Dr. Tanimu's diagnosis. Just keep it simple. Acute bacterial meningitis. They're not looking for too many ambiguous things, really. Listeria monocytogenes cannot come in as a comment. This is a non-alcoholic and the rest. So you will consider prophylaxis, management of this other thing. But the guy is correct. This is, Dr. Dahatu was spot on in his diagnosis. Besides that sporadic, he went to mission sharp. Keep it simple in exam and just look around what the case scenario they paint for you and just follow them like that. Don't go and start looking for trouble when there is no trouble. And one thing I once again I must appreciate Dr. Dahatu. I know you didn't have so much time to prepare for this presentation, and you gave us slides. You are not a neurologist. You went to town, did your research. We must appreciate you for this. This is not an attribute. Some of our participants, a good number of our participants have shown. You got your slide ready. So I just want to quickly make that comment. I appreciate your effort and it was a wonderful presentation, good delivery. So please, in exam, keep things simple. Don't go and start saying things that will put you in trouble, or something that is completely out of the marking scheme, and the examiner should just take you there. So please, that's just all I wanted to say. Let's not overflow the issue. Please, let's go over to the second presentation. Thank you.
Yes, Dr. Christopher, good morning, Dr. Shicho. So just to add to
Good
that,
morning.
yes, please note that sometimes, because I heard some people say, okay, they said streptococcus, strep pneumoniae, and they got the mark. Some people said Neisseria meningitis, they got the mark, they ticked something. It's possible that it's all there. In a question like this that has that, yes, it said it was causative organism. When you know that it can be more than one thing, Dr. Lightmechi back in the day will tell you, say all the three. Whichever was in the marking scheme, they have to mark it. If you said it, they have to mark it. You understand? So just say everything. You say what's causative organism? Well, it could be this, it could be this, it could be this. If it's whichever one is in the marking scheme, they'll mark it for you. They cannot say you did not say it. You don't get marked for saying you don't get marked for saying or down marked for saying the wrong thing. You only get marked for saying the right thing. So just better to say everything. That's what I was trying to point out.
Thank you, sir.
Yeah.
Thank you, Ma. I think, Ma, we should move to the next presentation. It's going to be Dr. Obundare Adewale, but he's involved in a
Next
journey
person,
this morning.
this you mentioned is on the road. The next presenter should present. But Ajibola is in class.
Okay,
I think
Dr.
it's the next
Ajibola
presenter.
Sanda can please present.
Good morning, Chiefs. Good morning, my teacher's consultant. Sorry, I don't have my slides ready yet, but I can present the question now.
That's fine. It's understandable. I also understand it's your second presentation, and I know the time we gave you guys is short. So really, I must appreciate your set. I really love the attitude. So please go
Thank you very
ahead.
much.
What you can do for us is help us with the slide later so that your colleagues can go through it quickly.
Yes, ma'am, I will do that. I'm trying to open the question now. So it's question 5B. It's 5B. Question 5B. 5A. So a 23-year-old lady presents with fever of 38.9 degrees centigrade.
Can you help us just project the question so that at least we'll see the question as you're presenting? That will help us also follow you with you, mentally know what you're presenting. If you can just present, yes, project the 5B question.
Okay.
Do you have the question ready, or somebody should just
Please, someone can just project it for me, please. I would really appreciate it.
Dr. Alhatu can do that for us.
So while he's doing that, maybe I'll just be reading it out. So a 23-year-old lady presents with fever of 38.9 degrees centigrade, lower abdominal pain, and reduction in urine output. She had an induced abortion 2 weeks ago. Her blood pressure is 65/40 millimeters of mercury, and her pulse rate is 112 beats per minute. And her extremities were cold. She had cervical excitation tenderness. Urinalysis showed protein 1+. Her serial investigations are shown below. So there is a table. Okay, good. Dr. Thank you very much for the slide. So question 5A. 5A. So the investigations are shown below. So that's the parameter urea. Then that's day 1, day 2, day 3. They say progressively increase in urea level. Potassium 5.1 on day 1, 5.2 on day 2, 5.6 on day 3. Creatinine in micromoles per liter 320 on day 1, 456 on day 2, 507 on day 3. Hemoglobin in grams per dl. They said anemia with progressive decrease in HB level. And urine output they gave us for day 1 and day 2. in 24 hours, 80 mils day 1, 86 mils in day 2. So question 1, what is the likely diagnosis? So the likely diagnosis in these patients is 1, an acute kidney injury secondary to post-abortal sepsis complicated by septic shock. That's my diagnosis for this patient. Number 2, list 4 differential diagnoses. 1 will be likely sepsis secondary to retained product of conception still in place. 2 might be a background chronic kidney disease, background chronic, likely CKD. 3 will be so at least for differential diagnosis. So we said retained product of conception, CKD, or differential diagnosis in this patient. So yeah, I'm just looking at this for the first time. So sorry, just give me a minute. The patient might be having an ongoing, maybe, although the parameter, there's nothing there to support it, maybe a DIC, and then 4 lower down the line, maybe severe malaria. So list 6 investigations that you will do that will be relevant to our management and what you will find in investigation. So I would like to do an abdominopelvic ultrasound scan, and in the abdominopelvic ultrasound scan, we want to rule out maybe retained product of conception, fluid in the pouch of Douglas, since she's still having cervical excitation, tenderness. We would like to do a blood culture because there is evidence of fever, evidence of septic shock. So we'd like to do a blood culture to isolate an organism. 3, we would like to do, she already has urea and creatinine done here with a full blood count. So we also like to do a transvaginal ultrasound scan for this patient. 4, we would like to do a CRP that will help us in both management and to monitor our response to management. 5, we would like to do a urinalysis. Okay, she already has the urinalysis being done over here. So we said we'd like to do an abdominopelvic scan, transvaginal, CRP, LDH, blood culture, chest X-ray in these patients. And then 6, we also like to do our viral screens. We want to do our viral screens as we might be preparing these patients for hemodialysis. So we like to do hepatitis B, HIV, hepatitis C. I think we've already mentioned 6 investigations. So which KDIGO staging is she at? The patients, this number 4 question is which KDIGO staging is she at? So this patient, we're already saying this patient has acute kidney injury. So she has creatinine of 507 micromoles per liter. Just a minute.
Stage 3.
Yeah, so we'll say the patient is the urine output. We can use the urine output to stage her. So we can say she's KDIGO staging of 0.3 mils per kilogram per hour for less than 24 hours. So that will be a stage 3 staging. And then for management, so for management, first of all, this patient will be managed in a high dependency unit or an ICU. She'll be managed in an ICU, and it will be a multidisciplinary management involving the nephrologist, the infectious disease specialist, the intensivist, the gynecologist, and I think those are the 4 people that will be pertinent in the management, and the emergency physician. So the nephrologist, the intensivist, the emergency physician, the gynecologist. And then, so for these patients, we want to start her on broad spectrum antibiotics, but keeping in mind that she already has an ongoing AKI. So we would like to use drugs that will not be nephrotoxic. So we want to do, and we're looking at the focus of infection being a pelvic infection. So we might want to use fluoroquinolone, and in this case, maybe moxifloxacin, given that it is excreted enterohepatically. Also, part of our investigations, we want to do an LFT for this patient. We also want to cover her with IV metronidazole for anaerobes. We also want to start on antibiotics immediately. We want to also resuscitate this patient's blood pressure. So the ABC of resuscitation, make sure our airway is patent, breathing, our circulation. We want to start on crystalloids to boost our blood pressure. We also want to group and cross-match this patient as there is evidence of ongoing blood loss with the anemia that is progressively decreasing. So we want to group and cross-match and transfuse this patient as appropriate. We also want to pass the central venous line to measure her hemodynamic status, since she'll be in an ICU, and she'll also be catheterized while we're monitoring her urine output. We also want to stop. We also want to discontinue all nephrotoxic agents that she might have been using prior to now, and and depending on the finding of the transvaginal ultrasound scan, if there is evidence of retained products of conception, you want to take this patient in for a removal of that, as that might be an ongoing focus of the sepsis. You also want to start this patient on inotropes because of the low blood pressure that we're having here, the hypotension. So maybe we want to give her IV dopamine, 250 milligrams into 50 mils of normal saline 12 hourly. We also want to plan this patient as there is a steady increase in her rise of creatinine. So based on our, we also want to, want to give her IV calcium gluconate for the potassium, and ultimately plan her for hemodialysis. But in this case, we would like to do either a SLED, which is slow low efficiency dialysis, because of her hemodynamic status, or if facilities are available, she will benefit from a continuous renal replacement therapy, which is the preferred route of dialysis in a patient in an ICU dependent patient, or a patient with hemodynamic instability like this one. Then, based on the result of our blood culture, we would want to switch our antibiotics to the culture sensitive antibiotics that has been revealed from the blood culture. We want to monitor our CRP, and we want to continue monitoring our response to the medications and dialysis with serial EUCRs, and also her urine output. Thank you very much. I think I will stop at this point.
Okay. Thank you, Ajibola Sanda, for this wonderful presentation. Thank you very much. The floor remains open for contributions for our colleagues and our senior colleagues that have just went through the exams. Thank you. Okay. Dr. Tanimu. Okay, let me say Dr. Alhatu first. Dr. Alhatu, you can say something.
Okay. Thank you very much, sir, for the wonderful presentation. For the differential diagnosis, I wanted to make contribution. I think for me, what I would have said for the diagnosis, I would say post-abortal sepsis would be my diagnosis. And then the differential diagnosis, I will bring Lassa fever first as the differential diagnosis, being her pregnant, having anemia, having kidney injury, and probably the season we are in now. I'll bring differential diagnosis of Lassa, or I will even say Lassa fever. As for I will say this different diagnosis: septic abortion, differential diagnosis, Lassa fever, PID, I would say the chronic pelvic inflammatory disease, and even ectopic pregnancy as additional part of my differential diagnosis. The most of the other investigation you mentioned, I think I'm okay with them, and the KIDIGO and the rest of the discussion. Thank you very much.
Thank you, Dr. Dalhat. Dr. Tanimu also want to say something. Please go ahead, sir.
Okay, thank you very much. It's a nice presentation. The essence of us contributing is for God to help us pass these exams, and God help us in addition. The issue of the diagnosis, I think if I say this is toxic shock syndrome, I think complicated by acute kidney injury, because they said there are features of shock that is called climate extremity, very low blood pressure in a patient who had abortion. So I think the diagnosis may likely be toxic shock syndrome. Management also, part of the investigation can include cervical swab culture and urine culture, because it's sepsis now. And resuscitation, it can be septic shock if you use IV fluid, adequate IV fluid without improvement, then you call it a septic shock. That is when you chip in the use of no adrenaline or adrenaline. But dopamine now is out of place due to some studies that were done in sepsis. So dopamine is not usually recommended. The recommendation is no epinephrine, if not is 0.5 milligram of 1 to 1,000 concentration on IM. So that is it. And also that is it. For the differential diagnosis, you can bring closer differentials. But I think most of us, when we said toxic shock syndrome, we were marked right. So thank you very much. An evaluation go further for counseling of the patient, because if they say abortion, it's likely that it's an unwanted pregnancy. You have to counsel her about the issue of health care to herself and other things. And it is when you use IV fluid that you have not achieved normal hemodynamic status, then you see a septic shock, where you chip in the use of no epinephrine, or if not available epinephrine, to have hemodynamic status. Thank you very much. But by and large, it's a very nice presentation. Don't forget about urine culture and also culture of the cervical swab culture, in addition to blood culture. Thank you very much.
Thank you, sir, for this good addition, sir. Thank you. More contributions, please.
Morning, my teacher.
So, okay. Good morning, ma'am. Dr. Rukaya want to say something. Go ahead, ma'am.
Thank you, Dr. Hia. Good morning, our facilitators and colleagues. Mr. by thanking everyone for their input. Dr. Christopher, to Remgos, all of thank you so much. To the presenters, well done. I just want to make a short comment. I don't know if this has been done previously about this exam, given how the discussion today went. Previous exams that we know that
Dr. Rukaya, if you be so specific to the college, we'll wait after we stop recording. I can call on you. If it's just this question, fine. Maybe it's going to be specific. We don't want everything to be added anymore. We observe that they might be following us too. That's why they have changed the pattern of the exam. So we don't want everything. Not all that we're doing should not be added there. So once we are going to be more specific, we'll stop recording. Then I'll call on you too. But if you want to make comment on this presentation, just you can go ahead.
Okay. It's a bit tight what I was going to say, but my point was for the questions, if you noticed, they asked specific questions, they wanted specific answers. So like the first question, and to an extent, even this one, what is the most likely diagnosis? Mention the most likely diagnosis. In all of what has been said, the unifying thing in this particular question is there's an acute kidney injury. So it needed to come out with the diagnosis. Dr. Nim, thank you very much for your contribution. I think, but some mentioned what the presenter mentioned at the diagnosis was abortal sepsis, completed with acute kidney injury, and it was taken. It needed to come out in the diagnosis. Then for the previous question, there was a lot of back and forth, I know, about etiology and all that, and I will not reiterate that. But they asked for what is the diagnosis? You had so many questions to answer in 10 minutes. What is the diagnosis? Mention the diagnosis: acute bacterial meningitis. That is that you can add, okay, this is likely not an epidemic type because he's the only one that is ill in the family. Move on. Most likely organism, strep pneumo. That's the most likely. There are many things pointing to strep pneumo. However, like Dr. Shitu said, if this was an epidemic, I'll consider Neisseria. Because of his background immunosuppression, okay, Listeria may be possible, but strep pneumo, like that. So for management, always try to classify or list your principles of management. For most diseases, you can do resuscitation, specific management, supportive management, complications, follow-up, and rehabilitation, which was missed a bit in the initial. So supportive management and looking for complications like serial UNE for SIADH, for AKI, and all of that was missed in the meningitis presentation, but could have earned more marks with that. So you resuscitate the specific management, same here. Look for complications. You already has hyperkalemia, you treat that, but you're looking for additional complications and all of that. Rehabilitation, follow-up, including all of the counseling, him for the alcohol and her for. So if you classify, it helps you answer, say a lot in a little time and like go through most of what would be needed to gain the marks. Thank you.
Chief Dr. Ogaya, thank you for this good addition. Thank you very much. I don't know whether I will hand over to our chief. If there is no more in the chat box, not much there. Ma, please, I think we're handing over to you, ma.
Sorry, before we hand over, I was going to ask